Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos. In this video, we will discuss wound healing, regeneration, and repair. Before going into the topic, let's discuss few important things. Before a cell cycle begins, all the labile cells, stable cells, and permanent cells will follow a cell cycle which includes synthetic phase, pre-synthetic phase, post-synthetic phase, and mitotic phase, and so on. So, and there will be prophase, metaphase, anaphase, and telophase. In the picture, if you can observe, there is a labile cell, example squamous cell. In the mitosis, it will go prophase, metaphase, anaphase, and telophase. Okay. Before going to the metaphase, the cells will go into a pre-synthetic phase, G1 phase. Then they will enter into a sta stable phase, that is synthetic phase. Then G2 phase. Then they will enter into the mitosis and meiosis depending upon the need. So there will be prophase, metaphase, anaphase, and telophase. The green arrows are indicated for a labile cell, and the orange is indicated for a stable cell, and the red is indicated for permanent cell. So out of all the labile cell and stable cell and permanent cell, in the previous videos we have learned that labile cells will go regular regeneration and repair, and they will be continuously dividing. Stable cells will divide up to a certain extent, whereas permanent cells will not be regenerated once they are damaged. Example for a labile cell is squamous cell, example for a stable cell is hepatocyte, and example for a permanent cell is neuron. As we discussed, in a labile cell, there will be G1 phase, S phase, G2 phase, and M phase in a cell cycle. In the stable cell, there will be G0 phase, synthetic phase, G2 phase, and M phase. Whereas in a permanent cell, that is like neuron, there will be cell death once the cell undergoes damage. There will not be any regeneration or repair. Wound healing. Let's discuss our topic, wound healing. There will be two types of wound healing. One is healing by primary intention and the other is healing by secondary intention. Healing by primary intention is seen in when there is a wound, and there will be healing when there are two edges that are opposed. And the healing by secondary intention will occur in unopposed edges. Healing by primary intention. There will be neutrophilic infiltration in the first 48 hours. Then the neutrophils are replaced by the macrophages in 3 days. There will be granular tissue formation by 5th day, and fibroblast proliferation and initiation of fibrosis by 7 to 10 days. And finally, the fibrous union by 1 week. These are the steps involved in healing by primary intention. In the picture, you can observe the diagram A, the incised wound as well as the suture tract on either side are filled with blood clot, and there is a inflammatory response from the margins. Whereas in the diagram B, there are spurs of epidermal cells migrating along the incised margin on either side as well as around the suture tract. You can observe granulation tissue formation also in this. From below it is starting. You can observe the regenerating spurs, neovascularization, everything in that. And you can also observe the formation of a scab. In the diagram C, you can observe the removal of the suture at around 7th day, resulting in scar tissue at the sites of incision and suture mark. In the healing by secondary intention, which is seen in unopposed edges, there will be larger fibrin clot and there will be dense inflammation and large amount of granulation tissue formation. Then severe wound contraction and scar formation will be seen in healing by secondary intention. So scar formation is seen in healing by second intention. Wound contraction is seen in healing by second intention, secondary intention. That is in opposite edges. So this is a picture showing the secondary union of skin wounds. In the diagram A, the open wound is filled with blood clot, red color, and there is inflammatory response at the junction of the viable tissue, polymorphonuclear cells that are neutrophils. In the diagram B, there are epithelial spurs from the margins of the wound meeting in the middle to cover the gap and are separating the underlying viable tissue from the necrotic tissue at the surface, forming scab. And in the diagram C, there is a collagen scar. After contraction of the wound, a scar smaller than the original wound will be left. This is one more beautiful picture showing the healing by first intention and second intention. If you observe clearly, there will be clean incision wound in first intention, early suturing will be there, and hairline scar will be there. Whereas in a healing by secondary intention, there will be gaping, irregular wounds, granulation tissue will be formed, and there will be epithelium growing over the scar in healing by secondary intention. So this is one more picture showing how and what happens in healing by first intention and healing by second intention at around 24 hours, 3 to 7 days, and in weeks. You can clearly appreciate wound contraction seen in healing by second intention. What are the differences between a primary union and a secondary union? There will be 7 differentiating points between a primary union and secondary union. This question can be asked for a 3 marks question. First, cleanliness of the wound. As I said, it is primary union is seen between the opposite edges. That is, the wound will be very clean, whereas secondary union will be unopposed edges, so unclean. Infection generally uninfected, as the wounds are between healing will be between opposite edges. Infection may be infected in secondary union. Surgically clear margins are there in primary union, whereas irregular margins are observed in secondary union. Sutures are used in primary union, whereas they are not used in secondary union. Healing, there will be scanty granulation tissue at the incised gap and along the suture tracks, whereas there will be exuberant granulation tissue to fill the gap in secondary union. There will be a neat linear scar as an outcome of the primary union, whereas there will be a contracted irregular wound as outcome in secondary union. Complications of a primary union will be infrequent. There will be a chance for epidermal inclusion cyst formation, whereas the complications for secondary union will be there may be a separation and may require debridement. So healing by primary intention and healing by secondary intention is over. Now we will see what are the steps that are involved in a wound healing. First, there will be thrombosis. Second, inflammation. Third, granulation tissue. Fourth step will be fibroblast proliferation and matrix accumulation. And fifth stage will be angiogenesis. Sixth step will be wound contraction. And seventh step will be accretion of tensile strength and remodeling. Steps in wound healing can be asked for 6 marks or 3 marks question. If they are asked for 6 marks questions, you have to write in detail about these 7 steps. Whereas if it is has given in 3 marks question, you just mention the names. First step is thrombosis, second inflammation, third granulation tissue formation, fourth fibroblast proliferation and matrix accumulation, fifth is angiogenesis, sixth is wound contraction, seventh is accretion of tensile strength and remodeling. So, in thrombosis, a clot referred as a scab forms as a barrier on wound, preventing the microbial invasion. Factors involved are factor 13A, transforming growth factor alpha and beta, platelet derived growth factor, and the source is plasma and platelets. In the second step, inflammation, there will be neutrophils infiltrating the wound to remove the microbes and necrotic debris. Plasma-derived fibronectin and neutrophilic debris acts as chemoattractants for the macrophages and fibroblasts. Macrophages will eat neutrophilic debris and release factors for fibrinogenesis or fibrogenesis and angiogenesis. The factors involved in inflammation step is transforming growth factor beta, and the source is neutrophils. Coming to the third step, that is granulation tissue formation. It is the transient specialized organ of repair composed of erythrocytes and fibroblasts, followed by single cell lined capillaries surrounded by fibroblasts and macrophages. This granulation tissue formation can be given as granulation tissue or granulation tissue formation for 3 marks question. Then you should write it is a transient specialized repair of organ consisting of erythrocytes and fibroblasts and single cell lined capillaries surrounded by fibroblasts and macrophages. The factors that are involved in granulation tissue formation are fibrin growth factor or fibroblast growth factor and transforming growth factor beta. Sources are macrophages and fibroblasts. So this is a picture from Harshmohan practical book for pathology. Thank you, Harshmohan sir. So for this wonderful picture, in this you can observe there will be a angiogenesis or neovascularization. Plasma cells are seen, macrophages are seen, lymphocytes are seen, and fibroblasts are also seen. There will be active granulation tissue consisting of inflammatory cell infiltrate, newly formed blood vessels, and young fibrous tissue in loose matrix. Simply, granulation tissue will have inflammatory cells, new vascularization or newly formed blood vessels, and fibrin or fibrous tissue in the loose matrix. Next, fibroblast proliferation and matrix accumulation. 2 to 3 days after the injury, the fibroblasts will start secreting the collagen, and that too specially collagen type 3. About 5 to 7 days, the collagen type 1 will be formed, which imparts the tensile strength to the wound. So in the MCQs, they may ask you which collagen is helpful in imparting the tensile strength to the wound. It is collagen type 1. The source is macrophages and fibroblasts. And the fifth step, angiogenesis, it occurs either from the endothelial precursors or the angioblasts, which travel from basement membrane to the inflammatory site. where they get transformed into endothelial cells, pericytes, and smooth muscle cells of the blood vessels. So, in the angiogenesis, the endothelial precursors or the angioblasts will travel from the basement membrane to the inflammatory site, where they get transformed into endothelial cells, pericytes, and smooth muscle cells of a blood vessel. It also occurs from a previously present vessel near the site by the degradation of the basement membrane and endothelial cell proliferation. So, as it is a involved vascular, so vascular endothelial growth factor is the factor involved. Source is macrophages and monocytes. Next step is wound contraction. It is done in specialized tissues of fibroblasts, and the types of cells are called as myofibroblasts or MFs. They contain actin, which has the contractile ability. Multiple myofibroblasts will form a tight junctions, and their contraction will lead to wound contraction. Factors involved will be transforming growth factor beta 1 and beta 2. Sources from platelets, macrophages, monocytes, and fibroblasts. Next step, seventh step, and the final step, accretion of the tensile strength and remodeling. Tensile strength is restored by cross-linking of the collagen fibers, and the remodeling occurs as wound site devascularizes. The factors involved in this step will be platelet-derived growth factor, fibroblast growth factor, matrix metalloproteinases enzymes will be there, and tissue inhibitors of this metalloproteinases. Sources are from the platelets, fibroblasts, and capillaries. So total 7 steps are there in steps of wound healing. First will be thrombosis, second will be inflammation. These two steps are needed. And the seventh step will be for tensile strength and remodeling, that is accretion of tensile strength and remodeling. And 3 marks question can be asked on the angiogenesis. Factors that are affecting the wound healing. They can be a local factor or a systemic factor. Factors affecting wound healing. Under the local factors, there are many causes or factors. One is blood supply, local infection, hematoma formation, foreign body, mechanical stress, necrosis, and the type of tissue involved, and nerve supply to the area where wound healing is needed. Coming to the systemic factors that will affect wound healing will be age of the person, whether anemic or not, drugs used, obesity, septicemia, uremia, vitamin C deficiency, diabetes mellitus, malnutrition, zinc and copper deficiency, and few collagen genetic diseases. Now we will discuss complications of wound healing. So these are all factors affecting wound healing, complications of wound healing, wound contracture, granulation tissue, all can be asked for 3 marks questions. And wound healing can be asked for essay also sometimes. So what are all the complications of wound healing? First, there will be chances for infection. Second will be there will be formation of implants, that is epidermal cysts, or there may be pigmentation in the region involved. There will be deficient scar formation, incisional hernia, hypertrophied scars, and keloid formations. Excessive contraction and sometimes neoplasia also will come as complication of a wound healing. In the picture, you can see there is a wound dehiscence, that is already healed wound can break up, rupture, and there may be ulceration in the wound, and there will be keloid and hypertrophied scars formation, and sometimes there may be in Burns case etc. there may be excessive contractures or contractions. Healing in specialized tissues. Fracture healing may be primary union when the ends of fractures are approximated, as is done by applying the compression clamps. In these cases, the bony union will take place with formation of medullary callus without periosteal callus formation. So, there will not be any periosteal callus formation, only medullary callus formation will be there in this type of fracture healing. In secondary union of fractures, which are more common, there will be procallus and osseous callus formation followed by remodeling of the bone. So, this is a picture showing fracture healing. In the picture A, you can observe the hematoma and local inflammatory response at the fracture site. In the diagram B, there is ingrowth of the granulation tissue with formation of soft tissue callus. And in the picture 3, there is procallus formation which consists of woven bone and cartilage with its characteristic fusiform appearance and 3 arbitrary components: external, intermediate, and internal callus. So in the diagram D, there is formation of osseous callus consisting of lamellar bone following the clearance of the woven bone and cartilage. And in the last picture, there is remodeling done in the bone ends. The external callus is cleared away and the intermediate cells or callus are get converted into lamellar bone and the internal callus developing a bone marrow cavity. So this is a microscopic picture of fracture healing with resulting newly formed bone and granulation tissue seen in picture. Complications of fracture healing. Earlier we have discussed complications of wound healing. Here we will discuss complications of fracture healing. One will be non-union, the other will be delayed union, or third will be fibrous union. Non-union may result if some soft tissue is interposed between the fracture ends, whereas delayed union may occur from the causes of delayed wound healing such as infection, inadequate blood supply, poor nutrition, movement, less mobility, old age, and so on. Fibrous union may result instead of osseous union if the fractured bone is not mobilized. If the immobilization of the fractured bone is not done. Occasionally, a false joint may develop at the fracture site, which is called as pseudoarthrosis. So, complications of fracture healing will be non-union or delayed union or malunion or fibrous union. Healing in neurons. While neurons of the brain and spinal cord lose their ability for regeneration as they are permanent cells and fail to get replaced, healing of the peripheral nerves occurs with limited regeneration, mainly from the proliferation of the Schwann cells and fibrils from the distal end. When coming to skeletal muscle healing, regeneration of skeletal muscle is similar to that of a peripheral nerve, and a damaged myocardium will heal by fibrosis. Smooth muscle has limited regenerative capacity. Healing of the mucosal surfaces is by regeneration of the epithelial surface and replaced continuously. Examples will be GIT mucosa, respiratory tract, endometrium. This picture is showing a liver and healing of the organs such as kidneys, liver and thyroid with limited regeneration and some healing by fibrosis. Classical examples will be cirrhosis of liver and chronic pyelonephritis. Now there is a stem cell concept, or in the exam they will ask you about the stem cells or regenerative medicine. Stem cell biology is at the forefront of healing of the injured tissues, treatment of the diseases, and holds promise for tissue transplantation in future. And the stem cells are the primitive cells which are having the capacity for self renewal, and that they can be modulated into multi-lineage differentiation. These stem cells will exist in embryos where they are more numerous compared to the adult tissues where there is less number of stem cells. The stem cells presence in the bone marrow has been known for long, and they have been used for blood cancers and many blood disorders. However, use of the bone marrow stem cells for other diseases and sourcing of the adult stem cells from other organs and their use for damaged organ is relatively new. So these stem cells can be asked for 3 marks question. So stem cells are primitive cells which will have the self renewal capacity, and they can be modulated to multi-lineage, and these will be existing in embryos and adults, but their will number will be more in the embryos. And the stem cells in bone marrow are used in treatment of blood cancers and many blood disorders. Thank you for patient listening. Please like, share and subscribe Dr. Ravichandra Official for more interesting videos.